And with that, we're going to move now to another chapter, chest trauma. And let me say at the very outset that in some ways, chest trauma is unconventional. In some way, chest trauma is different from traumas in other parts of the body. Because in most other parts of the body, we made the point already, penetrating injuries often lead to surgical exploration. In the chest, they rarely do. We're going to see when we review our vignettes that most penetrating injuries of the chest we can treat with just a chest tube. We also made a point earlier that blunt trauma and penetrating trauma are two different things. But in the chest, they are not. In the chest, we see injuries after blunt trauma that we typically think of as injuries due to penetrating weapons. And that's because if you get multiple broken ribs in blunt trauma, the jagged edges of the broken ribs can be driven into the chest by the trauma itself and become, in fact, penetrating weapons. So that the boundary, the distinction between penetrating and blunt injuries in the chest is a little blurry. Okay, with that background, let's begin to review specific vignettes. Vignette number 1. A 75-year-old man sleeps and falls at home, hitting his right chest wall against the kitchen counter. He has an area of exquisite pain to direct palpation over the 7th rib at the level of the anterior axillary line. Chest X-ray confirms the presence of a rib fracture with no other abnormal findings. Okay, so what do we do with a rib fracture? The problem with a rib fracture is it hurts every time you breathe. That probably would not kill a young, otherwise strong, healthy patient, but it could kill an old man like this one. He doesn't breathe because of the pain, he gets atelectasis, he gets pneumonia, he dies. It's very important that that pain be controlled. But you cannot use a lot of opiates to control the pain because that will depress the breathing and the patient will also get into trouble. Neither should you use an older answer to this kind of situation that said strap the chest. Put big adhesive tape so that side of the chest doesn't move. That will get rid of the pain, but in an old man will also lead to atelectasis and pneumonia. So the correct answer is topical anesthetic block. In fact, it's the correct answer for young or old. So you have a question on the exam, rib fractures, what do you do about them? Topical anesthetic block. Now we move to vignette number 2. A 25-year-old man is stabbed in the right chest. He's moderately short of breath and has stable vital signs. There are no breath sounds on the right, which is hyperresonant to percussion. This is a description of a pneumothorax, but I have to make an important distinction here because earlier we talked in the chapter on shock. We talked about tension pneumothorax as a potential reason for shock. But this is not a tension pneumothorax. This is a plain pneumothorax. Now, what's the difference between the two? In a plain pneumothorax, an injury has occurred, air has gotten into the pleural space, the lung is collapsed. But in the tension pneumothorax, the nature of the injury is such that a one-way valve mechanism occurs, whereby with every breath the patient takes, more air is added to the pleural cavity, but it doesn't get out during the breathing cycle. And so as you keep adding air, the pressure builds up and you get the tension pneumothorax with displacement of the mediastinum and shock. This isn't happening here. This is just a plain pneumothorax. So here the next thing you want to do is a chest X-ray. Something that I warned you not to pick as an answer on the previous cases when we were talking about tension pneumo. I said don't waste any time doing X-rays. You have a clinical diagnosis, you have to intervene. Here you do a chest X-ray, it will confirm that there is a pneumothorax. And then the treatment is a chest tube. It doesn't need to be preceded by a needle in a great big hurry. There is no great big hurry here. So you put a chest tube, preferably on the upper part of the chest, put it to underwater suction. Now we move to vignette number 3. 25-year-old man is stabbed in the right chest. He's moderately short of breath and has stable vital signs. The base of the right chest has no breath sounds and is dull to percussion. He has faint, distant breath sounds at the apex. Well, this is probably a hemothorax, and you're going to make the diagnosis with the chest x-ray. So the next thing you do here is chest x-ray. It should show the blood in the pleural space. What do we do next? Most patients who have penetrating injury to the chest and subsequently bleed into the pleural space, in most cases, the source of the bleeding is the lung, because the lung is the biggest target you could hit. And the lung has a low pressure circulation out of the right ventricle. And so the bottom line is that most patients who develop a hemothorax subsequent to penetrating injury of the chest do not bleed an enormous amount, and the bleeding typically stops by itself. They do not need an operation. However, they need an intervention because it's not a good idea to leave contaminated blood in the pleural space. That can lead to an empyema, which in turn can lead to all kinds of problems and complications. So this patient needs a chest tube like the previous vignette did. Except you don't want to put this one at the apex, you want to put this one at the base, where it evacuates the blood. And once you've done that, this chest tube will also help you decide if this might be the rare patient who injured a systemic vessel and in fact is bleeding massively and needs an intervention. Let me illustrate this with the next few vignettes. We're now on vignette number 4. A 25-year-old man is stabbed in the right chest. He's moderately short of breath and has stable vital signs. There are no breath sounds at the right base and only faint distant breath sounds at the apex. The right base is dull to percussion. Chest x-ray confirms the presence of a hemothorax. A chest tube placed at the right pleural base recovers 120 ml of blood and drains another 20 ml in the next hour. Let me ask you, is that an enormous amount of blood? Obviously it's not. And that tells you the source of the bleeding indeed was lung parenchyma. You have already put the chest tube, you've already done all the treatment that's needed. You don't need to intervene to stop the bleeding. It has almost stopped already. But in contrast with that, vignette number 5. 25-year-old man is stabbed in the right chest. He's moderately short of breath, has a blood pressure of 95/70, a pulse rate of 100. Marginal numbers. No breath sounds are heard over the right chest, which is dull to percussion. Chest x-ray shows a large hemothorax on the right. A chest tube placed at the right pleural base recovers 1,250 ml of blood. Now you realize that's an enormous amount of blood. This is indeed evidence that there is a systemic vessel responsible for the injury that will need to be tied off. Most likely, in fact, it will be an intercostal. This patient needs, we used to say, needs a thoracotomy. Today that we're in the age of minimally invasive surgery, actually it will probably be a thoracoscopic intervention, but you will not be asked for those details. All you need to know is this patient, by virtue of the amount of blood that was recovered from the chest tube, needs a surgical intervention to stop the bleeding. And you would have that same indication if you didn't get an awful lot of blood to begin with, but you get a lot of blood over the ensuing hours. Let me read the vignette. 25-year-old man is stabbed in the right chest. He's moderately short of breath, has stable vital signs. There are no breath sounds at the right base and only faint distant breath sounds at the apex. The right base is dull to percussion. Chest x-ray confirms the presence of a hemothorax. A chest tube placed at the right pleural base recovers 350 ml of blood. Now that's not a big number. On that basis alone, you would not say we need a surgical intervention, but keep reading. Over the ensuing 4 hours, he continues to drain between 200 and 300 ml of blood per hour. Now you realize that this is not insignificant bleeding. This is adding up. And this patient will need an intervention to stop the bleeding. He's probably bleeding from an intercostal vessel. We move to vignette number 7. A 25-year-old man is stabbed in the right chest. He's moderately short of breath, has stable vital signs. No breath sounds on the right. Hyperresonant to percussion at the apex of the right chest, dull at the base, and here comes now the critical thing. Chest X-ray shows one single large air fluid level. That's a hemopneumothorax. If the X-ray had shown multiple air fluid levels in the chest, that would have been a diaphragmatic injury with bowel up in the chest. But when you see this description, you know this is a hemopneumothorax. This patient can also be treated with one or more chest tubes. You could put one at the base, one at the top, one for air, one for blood. Or put one that is inserted at the base, driven all the way out to the top, that has multiple holes, so both the air and the blood can be evacuated. We now move to vignette number 8. A worker has been injured at an explosion in a factory. He has multiple cuts and lacerations from flying debris, and he is obviously short of breath. The paramedics at the scene of the accident ascertained that he has a large flap-like wound in the chest wall, about 5 cm in diameter, and he sucks air through it with every inspiratory effort. This is a classical injury, as a matter of fact. It's called a sucking chest wound. The question is, what should the EMTs do? Because if left alone, this patient will develop a tension pneumo. He's sucking air in, but not getting it out. The pressure is going to build up within that pleural cavity. So the first aid at the scene is to put a large occlusive dressing. Something that works fairly well would be Vaseline gauze and a big dressing which is taped on 3 sides. That way, when he takes a breath in, the Vaseline gauze seals the wound. If by chance he's going to get rid of some of the air during expiration, he can lift the dressing because it's untaped on one side and the air can escape. Once he gets to the hospital, he will need a chest tube and repair the wound. And now we're going to move to a vignette of blunt trauma to the chest that is going to need a very long discussion. All right, let me read vignette number 9, and as I said, we're going to have a long discussion afterwards. A 54-year-old woman crashes her car against the telephone pole at high speed. On arrival at the ER, she's in moderate respiratory distress. She has multiple bruises over the chest and multiple sites of point tenderness over the ribs. X-rays show multiple rib fractures on both sides. On closer observation, it is noted that a segment of the chest wall on the left side caves in when she inhales and bulges out when she exhales. Now, this lady has an obvious injury. She has a flail chest. You can tell that because you can see what we call paradoxical breathing. You can see a portion of the chest wall that is not moving the right way. And the treatment for this flail chest that she has is based on fluid restrictions, diuretics. If fluids are needed, use colloid rather than crystalloid. If she goes into respiratory failure, if her blood gases deteriorate, then she needs to be put on a respirator. And if she goes on a respirator, she will need chest tubes because she's got all of those broken ribs that have punctured her lungs. And if she is placed on a respirator, she could develop a tension pneumothorax as air leaks from the lungs. So respirator goes with chest tubes in this case. But that's not all there is in this vignette. Because the management of a patient that has sustained severe blunt trauma to the chest, specifically of deceleration type, in fact has 3 components. One component is the one we already talked about. Treat the obvious injury. But if that's all you do, that's not enough. The second component is monitoring for about 2 days after the trauma, because there are 2 conditions that could show up within those 2 days: pulmonary contusion and myocardial contusion. So for 2 days, this lady needs chest x-rays and blood gases, EKGs, and cardiac enzymes. But there is still more. A patient that sustains severe deceleration injury like this could have a traumatic transection of the aorta, and this may not be obvious right now. Now, I know what you're thinking. If she had a traumatic transection of the aorta, she would have exsanguinated at the accident site and she would be dead. And that happens to a lot of patients, in fact, who sustain a transection of the aorta. But there is a small subset of patients. When they have the deceleration injury, the mechanism is the aortic arch keeps moving forward because it's free to do so. The descending aorta is fixed, doesn't move. The aorta cracks at the junction. But it can happen in some patients that the intima cracks, the media cracks, the adventitia does not. And the adventitia holds the blood. They develop a hematoma, but they do not exsanguinate immediately. However, the adventitia cannot hold that blood there for very long, and eventually the hematoma breaks through and they die. So in a patient like this, we also need to find out, do they have a traumatic transection of aorta? We do that by looking at two things: the chest x-ray and a spiral CT scan of the chest. If the chest x-ray shows a wide mediastinum, that puts the patient in a high probability group to have a traumatic transection, but it's not completely diagnostic by itself. And by the same token, if the x-ray doesn't show a wide mediastinum, it's a low probability, but not completely ruled out. That's why we always need the spiral CT scan. Then once we've done the spiral CT, if the patient had a wide mediastinum, the spiral CT shows the lesion, we repair that lesion of the aorta. If the spiral CT doesn't show the lesion, and the chest x-ray had not shown a wide mediastinum, then we realize the injury isn't there. But if there is a discrepancy between the two, if the chest x-ray had shown a wide mediastinum, which we know means the injury is likely to have occurred, and then the spiral CT doesn't show it, then we proceed with an additional diagnostic step, which would be an arteriogram. Okay? Let me repeat this. Big deceleration injury. We treat the obvious injury. We monitor for 48 hours for pulmonary contusion, myocardial contusion, and we look at the chest x-ray and do spiral CT, all cases. In that chest x-ray and a spiral CT, a wide mediastinum with an injury to the aorta on the spiral CT leads to the repair. A wide mediastinum, no indication on the spiral CT, we need an aortogram. And no wide mediastinum, no injury on the CT, we're okay. A 54-year-old woman crashes a car against a telephone pole at high speed. On arrival at the ER, she's breathing well. She has multiple bruises over the chest and multiple sites of point tenderness over the ribs. Chest x-rays show multiple rib fractures on both sides, but the lung parenchyma is clear and both lungs are expanded. 2 days later, her lungs white out on x-rays and she is in respiratory distress. Here's an example of a patient who sustained blunt trauma, did not have signs of pulmonary contusion when she came in, but because we keep these patients under observation for 48 hours and we do x-rays and blood gases, we now realize later that she is developing the signs of pulmonary contusion. She now needs the treatment that we had talked about, which I'm going to repeat. Fluid restriction, diuretics. If fluids are needed, use colloid rather than crystalloid. If her blood gases have deteriorated, put her on a respirator and put chest tubes. Now we move to vignette number 11. A 33-year-old woman is involved in a high-speed automobile collision. She arrives at the ER gasping for breath, cyanotic at the lips with flaring nostrils. There are bruises over both sides of the chest and tenderness suggestive of multiple fractured ribs. Blood pressure is 60/45, pulse rate is 160, feeble. She has distended neck and forehead veins, is diaphoretic. The left hemithorax has no breath sounds and a hyperresonant to percussion. Does this vignette sound familiar? If you recently reviewed the vignettes on shock and the trauma patient, you should recognize these as an individual who has a tension pneumothorax. You might wonder, what is this vignette doing here where it doesn't say that she had a stab wound or a gunshot wound to the chest? How did she get a tension pneumothorax with blunt trauma? Well, you should already know the answer to that too, because we pointed out not too long ago that when you have multiple broken ribs, the jagged edges of the broken ribs can be driven in as a penetrating weapon. So indeed you have a tension pneumothorax where the penetrating agent was broken ribs. And what does she need? She needs a needle to the second intercostal space, let the air out, and then chest tubes. All right, vignette number 12. A 54-year-old woman crashes her car against a telephone pole at high speed. On arrival at the ER, she's breathing well. She has multiple bruises over the chest and is exquisitely tender over the sternum at a point where there is a gritty feeling of bone grating on bone, elicited by palpation. This is obviously sternal fracture, which a lateral chest X-ray will confirm and which will need to be wired together. But the important point of this vignette is right underneath that broken sternum is the heart. And the heart is at very high probability in this case of having sustained myocardial contusion. In fact, let me take this opportunity to digress for a second. I said very recently, severe deceleration injury requires that we treat the obvious lesion, that we monitor for pulmonary contusion, myocardial contusion, that we make sure that there isn't a traumatic transection of aorta. And you might ask yourself, how do you know when you read an exam question that it was severe deceleration injury? Well, it may say that. The car was going 100 miles an hour, crashed against another car at the same speed. That's big trauma. The vignette may say there were 5 people in the car, 4 were dead at the scene, 1 is the only survivor. That was big trauma. But there is another better way to tell you. There are 3 bones in the chest that are very hard to break. The first rib, the sternum, and the scapula. Any vignette that says to you there is a fracture of the first rib or a fracture of the scapula or a fracture of the sternum after blunt trauma, that was a big deceleration injury. So this patient needs the diagnosis of traumatic transection of the aorta to be specifically sought. Vignette number 13. A 53-year-old man is involved in a high-speed automobile collision. He has moderate respiratory distress. Physical examination shows no breath sounds over the entire left chest. Percussion is unremarkable. Chest X-ray shows multiple air fluid levels in the left chest. This is classic for a traumatic diaphragmatic rupture. That's bowel in the chest. Remember we talked about that? Multiple air fluid levels in a chest, and it's always going to be on the left side, not on the right, because on the right you have the liver in the way, the bowel cannot get up into the chest, but on the left it will. So this is a traumatic disruption of the diaphragm. You really have the diagnosis already from the way the X-ray is described. An nasogastric tube could be placed in the stomach. You would see that the tip goes up into the chest. And if you're not sure, a laparoscopic evaluation might give you the answer, and then a surgical repair follows. The next vignette is based on an actual case of an individual who does stunts for a living. Let me read it. A motorcycle daredevil attempts to jump over the 12 fountains in front of Caesar's Palace Hotel in Las Vegas. As he leaves the ramp at very high speed, his motorcycle turns sideways, and he hits the retaining wall at the other end, literally like a rag doll. At the ER, he's found to be remarkably stable, although he has multiple extremity fractures. A chest X-ray shows fracture of the left first rib and wide mediastinum. This, which was an actual case that really happened. You already know the significance here of two of the findings. You know that a first rib that is broken means big trauma, and you know that a wide mediastinum points to a very high probability of traumatic transection of aorta, which is what this gentleman had. When this gentleman was further evaluated, he was found to have a traumatic transection of aorta. When this happened, because this happened a number of years ago, it was evaluated with an aortogram. Today you would start with a spiral CT and then do the repair. Vignette number 15, a 34-year-old woman suffers severe blunt trauma in a car accident. She has multiple injuries to her extremities, head trauma, and pneumothorax on the left side. Shortly after initial examination, it is noted that she's developing progressive subcutaneous emphysema all over her upper chest and lower neck. There are three things that could give you thoracic subcutaneous emphysema. One would be rupture of the esophagus subsequent to endoscopy, which is not the background here. Another one would in fact be a tension pneumothorax that we have talked about before, but it would not be the most significant finding. The most significant finding in a tension pneumothorax is the shock with the big distended veins and the respiratory distress. And the third thing, which this one is, a transection or an injury to the trachea or a major bronchus. And we had already mentioned these apropos of airway. This individual needs now fiber optic bronchoscopy to make the diagnosis of a tracheal or major bronchus injury, and also to provide the airway. Because otherwise, if we blindly put a endotracheal tube pushing it through the vocal cords, not knowing where it goes, it will not end up inflating the lungs. It has to be, intubation has to be done over the fiber optic bronchoscope. Vignette number 16 is not a very common problem, but it's a good preamble to the vignettes that follow. A patient who had received a chest tube for a traumatic pneumothorax is noted to be putting out a very large of air through the tube, a large air leak, and his collapsed lung is not expanding. You have here another example of an injury to a major bronchus or the trachea, and it is evident by the fact that the chest tube cannot cope with the amount of air that comes from the injury. On vignette 17 now, this is the one that I was referring to that will be a good lead point for the two that follow. A patient who sustained a penetrating injury of the chest has been intubated and placed on a respirator, and a chest tube has been placed in the appropriate pleural cavity. The patient had been hemodynamically stable throughout, but then suddenly goes into cardiac arrest. What you have here is an injury to a bronchus, major bronchus, and an injury to a vessel next to it. So that once the patient is being ventilated with a machine that puts positive pressure in, the air can go into the vessels and eventually into the heart and produce air embolism. Let me read you two other vignettes that are better examples of air embolism in a more common clinical situation. During the performance of a supraclavicular node biopsy under local anesthesia, suddenly a hissing sound is heard and the patient drops dead. This is why anytime we manipulate things in here, we put the patient in Trendelenburg. Because if we make an injury to a major vessel here, major vein, we don't want air to be sucked in, we want blood to come out. But in this case, as this little removal of a supraclavicular node was being done, an injury was made at the time when the patient was inhaling, the air got in, air embolism, and he drops dead. Here's another example, vignette 19. A patient who's receiving total parenteral nutrition through a central venous line becomes frustrated because the nurses are not answering his call button. So he gets out of bed, disconnects the central line from the IV tubing. With the open catheter dangling, he takes 2 steps in the direction of the nurse's station and drops dead. Again, air got into a major vein when the patient inhaled. These examples of air embolism, the treatment consists of CPR. Put the patient left side down, right side up, hoping to keep that air in the atrium instead of all of it in the ventricle. If you have a tube in there at the time, try to suck it out. The prevention of these, though, is if we're going to have any opening into a major vessel here, we do it with a patient in Trendelenburg. And now we move to vignette number 20. A patient who sustains severe blunt trauma, including multiple fractures of long bones, becomes disoriented about 12 hours after admission. Shortly thereafter, he develops petechial rashes in the axilla and neck, fever, and tachycardia. A few hours later, he has a full-blown picture of respiratory distress with hypoxemia. Chest X-ray shows bilateral patchy infiltrates and his platelet count is low. I put this vignette here with the other vignettes of chest trauma, even though this is not a chest trauma problem. But it may get you confused with one because there's been trauma and then the patient is in respiratory distress. But you realize from the details that there is a time lapse, about 12 hours, between the trauma and the respiratory failure, and the trauma didn't break ribs, it broke long bones. What this is fat embolism, for which the patient will in fact need to be placed on a respirator, and that's the mainstay of therapy. So this is a good point to remind ourselves of the significance of pulmonary failure after trauma. So we distinguish these two situations, one where it is a chest injury that leads to the pulmonary failure, and one where you have a fat embolism. Let's cut away from my face and go to the words on the screen. So we have a question on the exam that gives you pulmonary failure after trauma. If the patient has multiple broken ribs, or a fracture of the first rib, or a fracture of the scapula, or a fracture of the sternum, you're dealing with pulmonary contusion. But on the other hand, if what you have is multiple long bone fractures and subsequent to that pulmonary failure, you're dealing with fat embolism. Now, if you had a vignette that said subsequent to trauma, the patient went into pulmonary failure, and you see a picture like I'm showing you, in which you see rib fractures, then you would realize that the reason for the pulmonary failure is pulmonary contusion. All right, this is such an important topic, but I want to repeat it with you, looking at what essentially is a decision tree. What is it that we do when we have chest trauma that happens to be blunt trauma to the chest, a severe deceleration injury? Well, we obviously have to treat the obvious injuries. In the vignette we just read, that was a flail chest, so we treat the obvious injuries. But that's not the end of it. We also need observation for 48 hours in case there may be myocardial contusion or pulmonary contusion that might show up later. And then we have to ask ourselves, is there transection of the aorta? And so to answer this question, is there transection of the aorta? We look at the mediastinum and chest X-ray, and we ask ourselves, is it wide? If it is wide, that injury is probable. We're not sure, it's not certain, but it's probable that that injury would exist. If it is not, the injury is unlikely, but we have not proven that it is not there. So in either case, whether that mediastinum is wide or not, we always do the spiral CT scan. So now we have done the spiral CT scan. If it reports aortic rupture, we do the surgical repair. But if that spiral CT scan is negative, then we have to think again, was the mediastinum wide? Because if that mediastinum was wide and the spiral CT is negative, we have to do an aortogram. But on the other hand, if the mediastinum was not wide and the spiral CT is negative, then no further workup is needed. And now we go back to our vignettes, and we're going to begin now abdominal trauma. A 19-year-old gang member is shot in the abdomen with a .38 caliber revolver. The entry wound is in the epigastrium to the left of the midline. The bullet is lodged in the psoas muscle on the right. He's hemodynamically stable. The abdomen is moderately tender. This is a pretty straightforward vignette. A gunshot wound of the abdomen like this one needs an exploratory laparotomy. There is now an evaluation ongoing of more conservative management for gunshot wounds with very small caliber in the right upper quadrant where only the liver could be involved. And some of these patients are being followed clinically and with CT scans. But as described this one, this patient needs an exploratory laparotomy. Now, vignette number 22 at exploratory laparotomy for the patient described in the previous question. Examination shows clean, punched out entrance and exit wounds in the transverse colon. Let's ask ourselves, why do we do exploratory lap following a gunshot wound to the abdomen? We don't do it to remove the bullet. We do it to repair the injuries that were made by the bullet. In this case, if you have an injury to the transverse colon, those exit and entrance wounds need to be repaired. In an earlier time, all colonic injuries had a colostomy done. This is not the case in civilian practice and hasn't been the case for a long time. Now we move to vignette number 23. A 19-year-old gang member is shot once with a .38 caliber revolver. The entry wound is in the left mid-clavicular line, 2 inches below the nipple. The bullet is lodged in the left paraspinal muscles. He's hemodynamically stable, but he's drunk and combative, and physical examination is difficult to perform. Now, I made the point that the vast majority of gunshot wounds to the abdomen lead to an exploratory laparotomy. But you might get a question on the exam that doesn't actually say this is a gunshot wound to the abdomen. It says it's a gunshot wound, and it gives you the entry wound and the location of the bullet, and you have to figure out, is that the abdomen? Well, a point that we always teach our residents as they begin to deal with trauma is that any gunshot wound below the nipple line involves the abdomen. Now, I'm not saying the chest ends at the nipple line. The chest continues up to the lower edge of the rib cage. But the chest and the abdomen are not stacked up like pancakes with a flat division between the two. There is the dome of the diaphragm. So there is a portion of the body that has both chest and abdomen. And in this case, then, this gentleman has both a chest and an abdominal injury, for which he requires a laparotomy. Now we move to vignette number 24. A 42-year-old man is stabbed in the belly by a jealous lover. The wound is lateral to the umbilicus on the left, and omentum can be seen protruding through it. Now, when we talked about penetrating injuries, we said a little earlier, we as a rule expect bullets will do more damage than knives. But a knife can, if the information in the vignette that makes it obvious, also be the source of an injury that needs repair. And here's an example. We can see omentum hanging out. This means that this knife blade entered the peritoneal cavity, and he may have injured something other than the omentum that is hanging out. So this patient needs an exploratory laparotomy. But in contrast with that one, in vignette number 25, In the course of a domestic fight, the 38-year-old obese woman is attacked with a 4-inch long switchblade. In addition to several superficial lacerations, she was stabbed in the abdomen. She's hemodynamically stable, does not have any signs of peritoneal irritation. So we have no signs of bleeding, no signs of contamination within the abdomen, no evidence of viscera hanging out. We were told at the very outset this is an obese lady, well padded, big subcutaneous tissue. This may not have entered. This knife may not have entered the peritoneal cavity. So the management here is sterile glove, clean the area real well, and in the emergency room you can gently probe the wound with your finger. If it stops short of entering into the peritoneal cavity, the lady doesn't need an exploratory laparotomy. If your finger, on the other hand, can easily get into the peritoneal cavity and feel the contents there, then we need an exploratory lap because that knife did get inside and it could have done damage. Now we move to vignettes that represent blunt trauma to the abdomen. A 31-year-old woman smashes her car against a wall. She has multiple injuries, including upper and lower extremity fractures. Her blood pressure is 75/55 with a pulse rate of 110 and a CVP of 0. On physical examination, she has a tender abdomen with guarding and rebound on all quadrants. So let me read the next, because you'll see that there is a common denominator to both of these. A 31-year-old woman smashes her car against a wall. She has multiple injuries, including upper and lower extremity fractures. Her blood pressure is 135/75 with a pulse rate of 82. On physical examination, she has a tender abdomen with guarding and rebound on all quadrants. In both of these individuals, subsequent to blunt trauma, they develop signs of peritoneal irritation, signs of contamination of the peritoneal cavity, and they will both need an exploratory laparotomy for that reason. Now, one of them also has signs of bleeding, but the other one does not. So the bottom line, anyone with blunt trauma who subsequently develops an acute abdomen needs an exploratory laparotomy. Now the next vignette, vignette number 28, is going to need a much longer discussion. Let's read it. A 26-year-old woman has been involved in a car wreck. She has fractures in both upper extremities, facial lacerations, and no other obvious injuries. Chest X-ray is normal. Shortly thereafter, she develops hypotension, tachycardia, and dropping hematocrit. Her CVP is low. This lady had blunt trauma. This lady is going into shock. And this lady has a low CVP, so this lady is bleeding internally. But where is she bleeding? We don't know. Well, let's go from head to toe and figure it out. Is she bleeding inside the head and therefore going into shock? No. We know there isn't enough room there to have 1.5 liters of blood. Could she be bleeding into the neck? She could, but it'd be obvious on physical exam. Severe distortion. She would look like a toad. How about the chest? Well, she could. The chest has plenty of space to accommodate 1.5 liters of blood, either in the mediastinum or a pleural space, but it could not hide from an X-ray machine. She had a chest X-ray that was normal. Blood isn't there. And that leaves through 3 places where it could be. In the abdomen, pelvic fracture, or femur fractures. Because we know those are the 3 places. In that quick physical exam that is done in a trauma patient as they come into the ER, we quickly see if they have a pelvic fracture or femur fracture by physical exam, and if needed, by X-rays. If they are not suffering from a pelvic fracture or femur fractures, the blood must be in the abdomen. But having said that, I hasten to add that we do not proceed with an exploratory laparotomy unless we are sure that indeed the abdomen is a source of the bleeding. We used to determine that by doing a little invasive study called a diagnostic peritoneal lavage that has essentially vanished from the picture because we now have 2 much better ways to make the decision. The best study we could do under the circumstances here would be a CT scan of the abdomen. The CT scan will show you the blood in the abdomen and will show the injury of the organ that is giving rise to the bleeding, and allow you even to make a good guess in conjunction with the response of the patient to fluid administration as to whether you need to operate or not. However, for purposes of the USMLE, to do a CT scan in a patient that you suspect has intra-abdominal bleeding, there is a very important requirement. The patient has to be hemodynamically stable. Because the assumption in the USMLE is that not every emergency room, not every teeny bitty hospital all over the nation has a CT scan machine available in the emergency room, and one of the newer models that can give you a very quick study. And so the assumption is a patient who's going to get a CT scan may have to be taken out of the emergency room, be taken to an X-ray department. It may take a long time for the study to be done, and you cannot do that if the patient is literally dying. So the patient has to be hemodynamically stable. So in the exam, if you have this vignette that I just read, and it says that the patient is hemodynamically stable, your answer is do a CT scan. But if not, the patient is not hemodynamically stable. The answer used to be do the diagnostic peritoneal lavage. Now that has been superseded for the most part by a quick sonogram that we can do in the emergency room. We call it by the acronym FAST, Focus Abdominal Sonogram for Trauma, which can very quickly tell you whether there is blood or not. It doesn't show you the organ that's injured. It doesn't give you as much detail as a CT, but under the circumstances would be enough to proceed then with exploratory laparotomy and stop the bleeding. Let me repeat this thing because this is a very important issue, and let's do it with a little bit of a decision tree. So we're going to cut away from my face and we're going to go to words on the screen. So we have an individual with blunt trauma, shock, a low CVP, with no obvious source of bleeding, and a normal chest X-ray. The blood is either hiding in the abdomen, a pelvic fracture, or femur fractures. We check the pelvic and the femur fractures by physical exam and, if necessary, by X-rays. If not found, then the blood is hiding in the abdomen. So if we suspect that the blood is hiding in the abdomen, if the patient is hemodynamically stable, that's a question we ask ourselves. Is this patient hemodynamically stable? If the answer is yes, we do a CT scan. But if the answer is no, then we have to do either the old diagnostic peritoneal lavage or that quick sonogram that we can do in the ER, the so-called FAST test. Let me add something while we're at this though. And a little note, in real life, that FAST test is often also run over the precordial area to rule out a coexistent pericardial tamponade. However, in the USMLE, where we tend to have more typical cases, the patient with a pericardial tamponade would be described as having a high CVP and distended neck veins. Here is a picture of where you can see a splenic laceration in an abdominal CT scan. Now, obviously, as we have discussed, this would have been a patient that you suspected had intra-abdominal bleeding. He was hemodynamically stable, and therefore you appropriately asked for a CT scan. And if they show you a picture like this, you can recognize then that the spleen is ruptured. Vignette number 29. A 27-year-old intoxicated man smashes his car against a tree. He's tender over the left lower chest wall. Chest X-ray shows fractures of the 8th, 9th, and 10th ribs on the left. He has a blood pressure of 85/68 and a pulse rate of 128, which do not respond satisfactorily to fluid and blood administration. You realize now as you're reading this patient could not have a CT scan done in the USMLE. He's not hemodynamically stable. So he has a positive peritoneal lavage, the older test you would have done under the circumstances, or it might have been the little quickly done sonogram. An exploratory laparotomy rupture spleen is found. They're not going to ask you in the USMLE, how do you do a splenectomy? Those are technical questions that don't appear on the exam, but you're expected to know what will the surgeons do. It used to be, there was a time when rupture spleens always led to splenectomy. We did not appreciate how important the spleen is. We now realize it's important for immunological competence, particularly in children. So the correct answer here is, if at all possible, the surgeons will repair that spleen. If they absolutely cannot repair that spleen, and the vignette were to say a splenectomy had to be done, then subsequently the patient needs to be immunized against the encapsulated bacteria to which now he would be vulnerable. And that includes pneumovax and immunization for Haemophilus influenza B and meningococcus. Now the next several vignettes represent new problems that we have not seen in the past, but are now seen quite commonly in patients that had severe abdominal trauma with multiple severe injuries, the kind of patients that used to die before they had medical care and now survive, but they survive at the expense of developing some important complications. Let me read the vignettes. This is now vignette 30. A multiple trauma patient is receiving massive blood transfusions as the surgeons are attempting to repair many intra-abdominal injuries. It is then noted that blood is oozing from all dissected row surfaces as well as from his IV line sites. His core temperature is normal. This is now such a common thing that we can predict it. We know that if a patient has had at least 10 units of blood or more, this is going to happen. They're going to develop a coagulopathy. And because we don't have the time under the circumstances to do an elaborate laboratory evaluation of the patient, we essentially treat these in a shotgun approach. We give these patients fresh frozen plasma and platelet packs, roughly 10 of each. Now the next vignette represents this same problem with an added feature. During the course of a laparotomy for multiple trauma, the patient develops a significant coagulopathy, a core temperature below 34, and refractory acidosis. We still have the same problem as before of a coagulopathy, but we also now have the problem of the hypothermia. If we keep operating in this patient, belly open, we keep working, he will die from a hypothermia. This man needs a fresh frozen plasma, he needs a platelet packs, he also needs to have the bleeding areas packed and a temporary closure of the abdomen done. We cannot continue to operate. At a future date, a day or two later, whenever he can be rewarmed and the coagulopathy is corrected, we then can go back and finish what we were doing. The next two vignettes are again another one of these new problems. Vignette 32. An exploratory laparotomy for multiple intra-abdominal injuries has lasted 3.5 hours, during which time multiple blood transfusions have been given and several liters of Ringer's lactate have been infused. When the surgeons are ready to close the abdomen, they find that the abdominal wall edges cannot be pulled together without undue tension. Both the belly wall and the abdominal contents seem to be swollen. This is the outcome that we see when it has taken a lot of fluid to resuscitate a patient, to keep him with good vital signs. And you put together all that fluid plus the inflammatory reaction in the bowel and the peritoneal contents that were injured, and the fluid ends up there, producing swelling and edema that prevent the closure of the abdominal wall. We call this condition, this is an unfortunate choice of name, we call it the abdominal compartment syndrome. I don't like the name because it confuses you with the compartment syndrome of the extremities that we will review later. But this is what we call it, the abdominal compartment syndrome. If we close this patient forcefully, he will develop pulmonary failure and renal failure. Pulmonary failure because the diaphragm is pushed way up, he cannot breathe. Renal failure because inferior vena cava will be pushed and the kidneys will not be able to drain the blood into the inferior vena cava. So a temporary closure is needed, a piece of plastic that is stapled all around the abdomen for the definitive closure to wait until a future time when it can be safely done. And vignette number 33 shows you what happens if this is not anticipated. On the first postoperative day, a trauma patient develops a very tense and distended abdomen, and the retention sutures are cutting through the abdominal wall. He also develops hypoxia and renal failure. This is what happens if we don't recognize that this abdominal compartment syndrome has occurred. The patient will develop pulmonary failure and renal failure. This patient needs to be open, needs to be have room for that edema to be there without occluding the inferior vena cava, without pushing the diaphragm up. A temporary plastic closure material, used, and then eventually the repair at a later date. These 4 vignettes that I read are the underpinning, the rationale for a recent trend in trauma surgery on very badly injured patients with multiple severe intra-abdominal injuries to do what we call a damage control laparotomy. That is, when we recognize ahead of time, if we were to do the extensive repair of everything, this patient will develop a coagulopathy or hypothermia or the abdominal compartment syndrome. We don't. We do a quick laparotomy, stop all the bleeding, do all the damage control that will save the life of a patient, do a temporary closure. And then at a later date, finish all the detailed repairs that were needed. Because if we try to do it all, we will have one of these complications developing.